All right, so good day, everyone. Good day, everyone. So for today, we'll be discussing about drug distribution in biopharmaceutical pharmacokinetics. So as you can remember, okay, from our previous discussions, we discussed about the absorption. Okay, so this time in class, we'll be discussing about the distribution or how drugs are distributed. Okay, so basically, class, we'll be talking about some factors affecting drug distribution, and at the same time, knowing some of the applications of distribution, specifically volume distribution, in terms of dosing and computing for dosages. All right. So for our topic outline for today, we will be discussing first the factors affecting distribution. So specifically, we will be talking about the membrane permeability, blood flow, plasma protein binding, and depot storage. Okay, now this one includes the topic on depot storage would basically be okay. So the topic on depot storage will be basically talking about the adipose tissues mostly. Okay, so we will be talking about lipophilic drugs here. Philic drugs. Okay, and of course the applications of volume distribution, specifically the apparent volume distribution, and its application in terms of dosing. So determining the dose frequency of certain medications, okay, and the like. So for today's objective class, we will be discussing, or our main objectives will be as follows. So first is to understand the concept of drug distribution, know the factors affecting distribution, be familiar with some terms used in drug distribution, understand how each of these factors affect drug distribution, familiarize on the concept of volume distribution, and know its significance and application. And with that out of the way, class, let's proceed to our first topic for today. So drug distribution class is the process of transporting drug molecules from the central compartment into the peripheral compartments. If you can remember, class, we've mentioned that when we talk about central compartment, we're specifically talking about the bloodstream, okay, or the general circulation. Okay, but basically, class, when we talk about central compartment, we're actually talking about not just simply the blood. Okay, we are referring to all organs having similar blood flow. Okay, I'm talking about blood flow here, class, because this will play a significant role in terms of distribution. So, class, when we talk about central compartment, again, these are organs having similar blood flow. In a sense, class, na ang kanilang blood flow is very fast. Okay, so these are drugs that are what we call the highly perfused, not drugs, organ systems. So these are the organ systems that are considered to be highly perfused. So that's the keyword here, highly perfused. All right? So it's transferred from the central compartment into the peripheral compartments. When we talk about peripheral compartment, class, these are organ systems mainly outside the bloodstream or the general circulation. Okay? Or these are some of the organ systems having different blood flows. Okay? Now we'll be talking more about, class, these compartment systems when we talk about the modules and compartments, all right, during our discussion. Right? But for now, class, if you can remember, absorption is simply the process of transferring the drug, the active drug, from the site of absorption, into the blood. So that's absorption. Now, class, we talk about distribution when the drug is already in the bloodstream and it's transferring to different organ systems, okay, such as organs for excretion, such as the kidneys, okay, organs for metabolic pathways. Specifically, we'll be talking about the liver here, right? That process, class, of transferring of drug from the central compartment or from the bloodstream into the different compartments, class, is known as distribution. So what are the factors affecting distributions? There are four main factors here. First is membrane permeability. Okay, this one's a bit self-explanatory. Okay, then blood flow, plasma protein binding, which plays a vital role in drug distribution, and depot storage. Okay, now first, class, let's talk about membrane permeability. Oh, sorry, what are other factors affecting drug distribution? So specifically, class, we can classify these factors as to those factors affecting the rate of drug distribution versus those factors affecting the extent. Remember, class, when we talk about rate, we're talking about how fast. And then when we talk about extent, we're simply talking about how much of the drug is being distributed. How fast is the drug being distributed here? Then how much? So what are those factors? Okay, in terms of rate, class, membrane permeability plays a good role here, and of course, blood flow. And as to extent, class, okay, plasma protein binding plays a vital role here. And then the other factors affecting this as well. Okay, so our first topic for the class will be talking about the membrane permeability. Okay, so how does membrane permeability affect drug distribution? As you all know, class, membrane permeability, in terms of membrane permeability, we're talking about the cell membrane here. And we know that the cell membrane is basically made up of lipids. So ano lang ang pwedeng pumasok ng mabilisan in terms of distribution, ha? Ano mga klase ng gamot na mabilis madidistribute ang sarili nila papasok sa cell? Okay, sabi natin, class, this would be, of course, lipid-soluble compounds. So lipid-soluble compounds, class, can easily go into the cell because of the lipid nature of the cell membrane. So, class, in terms of permeability, the cell membrane allows the easy distribution of lipid-soluble compounds into the cell, creating response. So, it's usually determined by the lipophilic character of the drug, and drugs acting on the CNS should be able to cross the blood-brain barrier. Another property, class, of the blood-brain barrier is that it's very permeable. It's very selective in terms of its permeability. So, oftentimes, class, the only drugs that can easily cross the blood-brain barrier are the lipophilic ones, such as anesthetic drugs, okay, benzodiazepines. These are often lipophilic by nature. Okay, and what else? So, other lipophilic medications, class, these are the type of drugs that can easily penetrate into the blood-brain barrier. Okay, so what else? This is the reason the membrane permeability of our blood-brain barrier is one of the main reasons why some drugs that should be acting on the brain cannot work. Okay, so a good example of that, class, would be antibiotics. If you take antibiotics, class, for meningitis, normally you don't take them orally. Okay, one way would be to give it intraspinally. Okay, sa spine na i-administer mismo yung antibiotics because alam kasi nila na yung drug hindi magko-cross ang blood-brain barrier yun kung ilagay ko lang simply sa bloodstream. So kailangan siyang i-directly administer via the CSF, okay, para umakyat papunta ng brain, para ma-bypass yung blood-brain barrier. Okay? Or some antibiotics, class, do have lipophilic characteristics. So these are drugs that can be administered intravenously, and we expect good amounts of this drug crossing the blood-brain barrier. Okay? Another example of this one, class, would be the drug levodopa. Okay? Because of the membrane permeability of the blood-brain barrier, okay, kunwari ito yung blood-brain barrier. So it usually does not allow the entry of dopamine. Okay? It usually doesn't allow the entry of dopamine. Okay, because of its selective property. It's because it's semi-permeable property. Okay. However, class, levodopa, which is usually used for Parkinson's disease. Okay. Ang problem kasi, class, with Parkinson's disease, just so you know, Parkinson's disease have low levels of dopamine in the brain. Okay, mababa yung levels of dopamine in the brain. So what happens here, class, is we want to replenish the total dopamine that you have in the brain. Okay, to prevent to make your movements more fine, mas finesse. Okay, usually, ang target kasi nito is the dopamine levels in the nigrostriatal pathway of the brain. You learn more about that, class, in pharmacology. Pero if you think about it, the rational way to handle Parkinson's disease would be to give you dopamine. Pero, class, if you give dopamine exogenously, it cannot cross the blood-brain barrier. Okay? But giving levodopa, on the other hand, levodopa allows, the blood-brain barrier allows the entry of levodopa. Then once levodopa goes inside the brain, levodopa is converted to dopamine inside the brain na. So therefore, increasing the amounts of dopamine in the brain, managing therefore the symptoms of Parkinson's disease. So that's how permeability or membrane permeability can affect drugs distribution. Right? And certain anti-cancer agents, which gives poor passage to the CNS. All right? So the blood-brain barrier class, it may be semi-permeable, but it is permeable to certain medications. As we mentioned earlier, lipophilic medications class can easily enter into the blood-brain barrier. So examples of which are, of course, caffeine. Okay, alam naman natin to. When we want to stay awake, when we're preparing for quizzes, and so on and so forth, we usually take caffeine. And caffeine class can easily enter into the blood-brain barrier because of its lipophilic characteristics. Okay, and work there to elicit its response, which is, of course, to awaken you. Okay, same goes class with LSD. LSD is lysergic acid diethylamide. So it's a recreational drug. Okay, I think familiar na sa pharmacology nito pag-uusapan ng bongga. Okay, but it's a recreational drug class that can easily penetrate into the blood-brain barrier, creating immediate response or immediate effects. Okay, another example class of membrane permeability that affects drug distribution would be, of course, placental transfer. So certain medications class, the placenta is basically a semi-permeable membrane. It doesn't allow the entry of most substances. Pinipili lang ng placenta ang papasok sa kanya para ma-reach si baby. Okay? Now, there are some medications class that can penetrate into the placenta, affecting its distribution therefore. So, of course, ang pinaka-popular would be thalidomide. Okay, alam naman natin, this is already a category X. Pregnancy category X, meaning it's dangerous for a pregnant woman. It's dangerous for the baby. Okay? So, alam naman natin class that thalidomide can cause a condition known as phocomelia, wherein babies are born without limbs. Okay? Ito yung pinakasikat na drug doon that launched the FDA to do clinical trials prior to the approval of medications to be marketed. Okay, then we have sulfonamides. Steroids can cross the placenta, just so you know. Okay, sulfonamides class, these are antibiotics. So, bawal din yun for pregnant women because it can, again, cross the placenta. Steroids, anticonvulsants, kaya class halos lahat ng anticonvulsants, either category D or category X for pregnant women. So, bawal talaga siya. And these are all teratogens. Okay? So, they can cross the placental barrier, okay, affecting the fetus. So, basically, class, ang placenta lang naman, ang gusto ko lang i-point out dito is, placenta class is semi-permeable. Okay? It usually doesn't allow the entry of certain chemicals. Okay? But there are chemicals that can easily penetrate the placenta. And these are some of the examples. Okay? So, these are drugs with high distributive property to the placenta. So what are other pathophysiologic conditions altering permeability of cell membranes? Having burns or meningitis. Okay, with burns class, it alters the permeability of the skin and allows drugs and larger molecules to permeate inward or outward. Remember class that the skin is one of the primary barriers, okay, of our body. Okay, this is a barrier. It separates our insides from the outside environment. Okay, so if you burn the skin class, okay, losing the skin would therefore expose the inside environment of your body to other stuff. So therefore, anything class, so when you have burns, okay, it allows the easy permeation of certain chemicals or drugs into your body. Kasi wala na yung barrier. So that's the point there. Okay, what about meningitis? Meningitis class is a condition wherein the meninges, yung grooves inside the brain. Okay, di ba ang brain natin is like this. Kunwari ganito. Okay, you'll see grooves there. Okay, yung grooves na yan. Those are called meninges. Okay, and these meninges class can be inflamed in the presence of bacteria. So once these are inflamed, we call that meningitis. It could be due to a bacteria, okay, or could be due to a virus. Depends kung whatever microorganism will cause the meninges to inflame. Pero once those meninges are inflamed class, ang tendency parang numinipis yung membrane. Okay, as the meninges enlarges, okay, the membrane surrounding the meninges becomes thinner. Therefore, class, drug uptake into the brain is enhanced because of the thinning of the membrane covering the meninges. Okay? So, drug uptake will be enhanced here. Alright. So, this time naman, class, let's talk about the main or the most significant, what do you call this? Okay, the most significant factor affecting drug distribution, which is blood flow. So, class, how a drug distributes is very dependent on the blood flow. So basically, class, the faster your blood is flowing, increase in blood flow, obviously, class, will also increase your, okay, the distribution of certain medications. That's the reason why, class, pag ikaw ay kinakabahan, in an emergency situation, class, or when you are stressed, tendency is the heart starts to pump really fast. Okay, the heart pumps fast, class, so that the blood flow will increase. By increasing the blood flow, the distribution of nutrients, oxygen, and other essential chemicals inside the body, class, will be distributed throughout the entire body. Okay, so therefore preparing your body in case of an emergency situation. Right? That's the reason why, class, an increase in blood flow will definitely affect distribution. So, basically, class, the blood flow carries drug molecules to the target site and to other tissues and organs. So it's the rate limiting step in the distribution of most drugs. Meaning, class, how a drug distributes, okay, once again, is very dependent on the blood flow. Faster blood flow would mean faster distribution. Slower blood flow would mean slower distribution. Okay. Another term, class, I want you to take note of here is the regional blood flow. Okay, regional blood flow. It refers simply, class, to the amount of blood delivered to different organs. So each organs, class, in our body have different blood flow. Okay. Normally, class, the brain has very high blood flow, pero whenever we eat, ang tendency kasi is 28% of the cardiac output goes into the GI tract. So therefore, class, nade-deprive ang brain of the essential blood that it needs. So therefore, whenever we eat, oftentimes we feel sleepy because the brain is deprived of certain nutrients like oxygen, for example. Okay, and it's an important factor in determining the initial drug distribution. Okay, now, yeah. So basically, class, the absorption of drug, especially from the GI tract, is very much dependent on the regional blood flow, or what we call the splenic blood flow. Okay, the blood flow that goes towards the GI tract. Okay. So tissues that receives highest blood flow will rapidly equilibrate with the drug. Example of which are lungs, kidney, liver, heart, and brain. Now, these are actually organ systems, class, under the central compartment. Okay? Ito yung mga organ systems that are under the central compartment. So, again, binanggit ko kanina, the central compartment, class, are organ systems or organs which have high blood flow, or these are highly perfused organs. So, yun siya. High blood flow. So, the CNS allows for lipophilic drugs to permeate across the CNS. Okay? Okay. So, poorly perfused tissues will equilibrate with the drug more slowly, like skeletal muscles, bone, and adipose tissues. Now, these poorly perfused tissues, class, are actually part of the peripheral compartments. Okay? So, ito yung mga organ systems or tissues, class, that are poorly perfused. Hence, they are categorized under one compartment. So, tinatawag na lang sila na peripheral compartment. Okay? We'll talk more about this, class, when we talk about the models and the various models and compartment models being discussed in pharmacokinetics or used in pharmacokinetics. Alright? But for now, gusto ko lang maalala nyo dito is that an increase in blood flow, again, would increase distribution. Another important parameter, class, that we have to talk about here this time would that affects blood distribution would, of course, be protein binding. Okay, what is protein binding all about? Okay, most drugs, class, ang tendency kasi is to bind to proteins. All right, so it depends on what would be the pH of the drug first. Would it be acidic or would it be basic? Okay, pero basically, class, some drugs have very high affinity towards proteins found in the bloodstream. Okay, what are the common proteins found in the bloodstream? Oftentimes, class, we have albumin, and then we also have alpha-1 acid glycoprotein. Okay, so the more a drug binds to a protein in the bloodstream, ang tendency is it cannot work. All right, so therefore affecting how well a drug distributes, okay, to other compartments or organ systems. Okay, so the binding of drugs to plasma protein reduces the amount of free drug in the blood. Now, basically, class, ano bang nangyayari pag na-bound ang isang gamot? So, assuming, class, this is the bloodstream. So, here's the bloodstream. Okay, ito kunwari yung ugat. This one. Alright? So, normally, class, when a drug is free, okay, say, for example, like this one. Itong green na to. These green ones. These are free drugs. As long as they are free class, they can easily escape the bloodstream. Okay? So, free drugs can escape, the bloodstream. And when they escape the bloodstream class, obviously, they can easily go to their target sites. Kasi most of the time naman, these medications, ang target sites nila are outside the bloodstream. The bloodstream is simply serves as a highway kung saan dumadaan sila to be distributed to their target sites. Now, what happens, class, if a drug is bound? Okay, such as these drugs. These are protein-bound drugs. Okay, remember, class, that proteins, these are macromolecular structures. These are large structures. So, meaning, class, if a drug is bound, class, it cannot escape the bloodstream. Bound sila eh. Okay, at the same time, ang laki nila. So, hindi sila magkakasya palabas ng bloodstream natin. Okay, because they are bound to certain proteins. Therefore, class, what happens here? Okay, hindi ngayon makalabas ang drug, so therefore, it cannot go to its target site. So, what happens to the effects of the medication? Wala. Okay, so they do not have pharmacologic effects because they cannot escape the bloodstream. Okay, and go to their target sites, which is, of course, the receptors. That's the reason why, class, only free drugs are the only ones with pharmacologic effects. Now, what about in terms of clearance? Okay, again, class, remember that bound drugs are bound to large molecules such as protein. Okay, so kumbaga yung gamot natin, class, lumalaki siya. Right? Now, once the drug is being transferred to the kidneys for elimination, normally, class, ang kidneys natin, it serves as a filter, right? Okay, ito kunwari yung kidney. Okay, isipin nyo, class, yung nephrons dyan are mesh wires. Okay, mesh wires yan. So, sinasala nila, class, yung lumalabas sa kidneys. Normally, class, if a drug is free, maliit lang siya. Okay, it's unbound. So, it can easily cross the mesh wire for parang the nephrons. Isipin nyo, parang mesh yung yung nephrons na yan. Parang siyang filter kasi. Okay? So, it can easily pass through the nephrons and be eliminated. Therefore, these free drugs, a free drug, can be eliminated or cleared from the body. Right? I hope that makes sense. Now, imagine, class, a free drug bound to a protein. Okay? So, yan kumara yung protein na yan. So, class, dahil nakabind siya sa isang malaking protein, ang gamot natin, hindi siya ngayon hindi siya kasya sa mesh wire na yan or sa filter ng ating kidneys. So, therefore, class, ano nangyayari? Ang tendency, class, is bumabalik na lang sila ulit sa bloodstream. Okay? Therefore, preventing the clearance of protein-bound drugs. Alright? So, basically, class, an increase in protein binding would mean a decrease in effects, therefore, reducing also the drug's clearance. Hindi siya nakiklear eh. So, dahil hindi nakiklear, class, ang drug, anong effect ngayon ito sa half-life niya? Dahil hindi siya lumalabas, humahaba tuloy yung half-life ng gamot because it stays longer inside the body. Pero nag-stay nga siya, wala naman siyang ginagawa kasi nga bound siya. Wala siyang pharmacologic effect na pinoproduce. Alright? Okay, so class protein-bound molecules are not available to exert pharmacologic effects, and not only that, they cannot also be cleared. Hindi rin sila maklear sa katawan natin. So therefore, class, it just stays inside the body. Alright? So that makes sense. Now, one of the concerns lagi dito, class, is, okay, anong klaseng bonding ba ang nangyayari between a drug and a protein? Remember, class, that protein binding is a reversible process. Okay? Ibig sabihin, ayun, makes sense naman, diba? Reversible siya. Alright? So, therefore, class, what type of bond exists between a drug and a protein? Oftentimes, class, the bond that exists between a drug and a protein is a hydrogen bond. Because hydrogen bonds, class, are reversible. Okay? Ito yung these are the type of bonds that exerts van der Waals forces. Okay? Na alam naman siguro class, di ba, ang covalent bond, rare ito for protein binding, pero it does happen from time to time. Covalent bond kasi class is irreversible. Okay? Oftentimes, it's a permanent bond between a protein and a drug molecule. Oftentimes, class, covalent bond exists between a drug and a receptor. Okay? Pero in terms of drug and protein in the bloodstream, okay, oftentimes, class, reversible naman yung process na yon. So, ibig sabihin, in due time, okay, yung mga bound drugs, marirelease din yan. Okay? Kumbaga, mag-aantay nga lang tayo ng a few moments, okay, or mag-aantay tayo ng konti for the drugs to be released back as free drugs in bloodstream. Okay? So, since andito na naman tayo class sa protein binding, i-relate na rin din natin to sa volume distribution. Now, we've had topics about volume distribution before, right? Okay, when we were discussing about the Ladmer system, okay, as an introduction. So, sabi natin, class, ang formula ng VD, simply dose over plasma concentration. Okay? So, ibig sabihin, class, volume distribution is directly proportional to the dose, meaning the higher you give a drug's dose, okay, the higher the dose of a drug, ang tendency is, mas mabilis siya mag-distribute. Okay, which makes sense din naman because you'll have more free drugs available. Okay? Pero ito, class, inversely proportional daw ang volume distribution sa plasma concentration. Ibig sabihin, kapag mataas ang amount of drug in the bloodstream, mababa ang distribution. And we know, class, that distribution or volume distribution is directly proportional to your distribution or extent, sorry. Let me correct myself. Is directly proportional to the extent of distribution. Meaning, the higher the VD, the more extensive a drug's distribution is. Okay? So, class, using this formula, using this formula, we can see, class, that an increase in drugs, an increase in the in the amount of drug in the bloodstream would lead to a decrease in VD. Bakit kaya? Ibig sabihin lang ng class, di kasi lumalabas ang gamot sa bloodstream natin. So, as long as the drug stays in the bloodstream, automatic, assume na natin agad na hindi yan nag-distribute kasi nasa bloodstream lang siya. Hindi siya kumakalat. Okay, so therefore, that affects volume distribution as well. Alright? So, that's the reason why also, class, if there's an increase in protein binding, okay, ang tendency is there's a decrease in the volume of distribution. Alright? Okay, so just so you know, class, volume distribution is a pharmacokinetic parameter used to determine the extent of distribution. Okay, we'll discuss more about this in a while. Okay, pero yun gusto ko lang ma-point out sa inyong lahat. Okay, alright. Now, what are the proteins, class, in the bloodstream where most drugs bind to? Okay, there are two major proteins, class, in the bloodstream. We have the albumin and then the alpha-1 acid glycoprotein. Now, between the two, class, mas prominent si albumin. Ito yung major protein that binds to most drugs in the market. Okay? Bakit? If you remember, class, most drugs, okay, most drugs in the market are weak acids. Well, weak electrolytes in general, yes. Pero most of them are weak acids. And guess what is the pH of albumin? Albumin, class, is basic. Okay, so may bonding between the albumin and the weak acid drugs. Okay, that's the reason why, class, it's the major plasma protein responsible for protein binding of drugs, specifically for acid and neutral drugs. Okay? On the other hand, ano naman yung mas madalas na nagbabind sa basic drugs? Anong protein na nagbabind sa mga basic drugs? The alpha-1 acid glycoprotein. Okay? Hope that makes sense, ha? Acid and base, right? So, may affinity sila towards each other. Okay? Yan. So, the extent of plasma protein binding, class, may significantly influence distribution, clearance, and efficacy of drugs, as I mentioned a while ago. So, as I told you a while ago, okay, as a recap lang, as a final recap, increase in protein binding would mean the drug stays in the bloodstream. Okay? Drug stays in the blood. So therefore, hindi siya lumalabas sa bloodstream. That reduces its efficacy. Okay? Because it cannot bind to its target sites. The drug is just staying inside the bloodstream. At the same time, because the drug is bound to a large molecule, hindi siya ma-filter out. So therefore, it decreases the drug's clearance. At kapag nabawasan ang clearance ng gamot, ano nangyayari sa half-life? It increases kasi hindi siya ma-eliminate. And at the same time, class, dahil protein-bound ang gamot, okay, because protein-bound siya, nasa bloodstream lang, ano nangyari sa kanyang distribution? So, bumababa ang distribution, ang distributive property ng gamot natin. Alright? So, I hope that makes sense. Okay. So what are some factors, class, that can influence protein binding? So first would be the number of drug binding sites on the protein. Okay, as long as di siya nasa-saturate, it can bind to multiple, the protein can bind to multiple drugs. Alright? So what else? Protein concentration. Of course, the more proteins you have in the body, the more chances na ang gamot mo ay mababind sa kanila. So halimbawa, paano kung mas marami ang protein kaysa sa gamot? So, ang tendency, class, is majority ng gamot na to mababound sa proteins natin. Kaya oftentimes, class, if a patient has, excuse me, if you know, class, that a drug has high protein binding, example of which would be phenytoin. Okay? Normally, class, if you're going to give phenytoin, ang loading dose niyan mataas. Bakit? Kasi ine-expect na nila na majority ng phenytoin ko magbabind sa proteins. So, bakit ko tinataasan ng dose? Para yung excess na tinaas ko, okay, I'm hoping na yun yung magiging yun yung excess drug that will stay as a free drug. Yung hindi magbabind. Kasi yung una kong dose, yung usual dose niya, na binigay ko, in-expect ko, magbabind lahat yun sa mga proteins na available sa bloodstream ng patient ko. So now, pag nagbind na doon lahat ng gamot ko, ang tendency is, masasaturate ko yung protein sa bloodstream. Okay? Now, of course, yung excess na ibibigay ko, parang ano yan, oversaturated na siya. So therefore, it's going to stay as a free drug. Hopefully. Kaya normally, if, again, a drug has high protein binding, normally, class, ang loading dose ko rin is mataas. Okay, so that yung excess na gamot will serve as a, as the free drug to elicit a response. Gagawin ko na lang afterwards, class, although mataas ang loading dose ko, usually ang ginagawa ko sa maintenance dose, dose ay binababaan ko. Bakit ko naman ngayon binabaan ang maintenance dose ko? Kasi, pag mababa, kasi class, the moment I give my drug, okay, tinaasan ko yung loading dose, ang tendency, some of those drug will be bound to the proteins. Pero sabi nga natin, hindi naman permanent yung bonding na yon. Okay, it won't be permanent. So therefore, class, sooner or later, i-release din yan. Okay, now isipin nyo lang, class, paano kung regular ang maintenance dose ko? The usual maintenance dose lang. Tapos biglang yung na-protein bound, ni-release. So, sobrang taas naman ng dose ngayon na makukuha ng patient ko. Baka ma-overdose naman siya. Alright? So, that's why you just slow down, decrease the maintenance dose to anticipate, class, the release of the drugs from the proteins where they are bound to. Okay? Again, class, protein binding is a reversible process. Alright? So, protein concentration can affect protein binding, obviously. So, effect ng protein synthesis in terms of liver disease. Normally, kasi when you have liver disease, mababa ang albumin levels. Right? So, affected din yung protein binding ng gamot. So, halimbawa, alam ko naman na highly protein bound ang drug to. So, automatic, bibigyan ko ng mataas na dose, di ba? Eh, paano kung may liver disease pala siya? Konti lang yung albumin levels niya. Tapos, mataas pa ng bigay kong loading dose. So, kawawa naman yung patient. Okay? So, these are some things, class, that you have to consider prior to dosing. Right? Disease states. Anong meron sa patients natin? Now, topics regarding that, class, would of course be more focused on the clinical aspects of pharmacokinetics. Okay, you want to learn more about that? Try to study, class, higher degrees of pharmacy, such as PharmD. Okay, pinag-aaralan yan sa PharmD. Mga ganong klaseng scenarios. Right, protein catabolism, such as in trauma or surgery. Distribution of albumin between intravascular and extravascular spaces, such as in the case of burns. Okay, and excessive elimination of plasma proteins, such as in renal disease. Okay, di ba normally, you don't see proteins in the urine, class. Pero if you have a renal disease, like say for example, diabetes or in nephrotic na ang inyong kidneys, may tama na yung kidneys. So tendency is lumalaki na yung butas, yung nephrons, yung filter ng ating kidneys, kaya nakakalabas na dun yung proteins na dapat hindi talaga lumalabas. Right? So yun, excessive elimination of plasma proteins such as renal disease, which causes a decrease in protein. At pag mababa ang protein, less protein binding. Okay, so kung less protein binding, huwag nyo masyadong taasan ang dose ng isang highly protein-bound drug. Kasi nga, konti na lang yung proteins na meron siya. So, I hope that makes sense, class. Okay, just so you know, mga quizzes ko dito, mostly scenarios. Okay? What else? Other factors would include lipid solubility of the medications. Weak acids are more bound, more extensive than weak bases because, again, ano ba ang predominant na protein sa blood natin? It's albumin. Okay, hope that makes sense. And then competing molecules. So binding is altered by other drugs as a result of drug competition resulting to drug displacement. Now, in terms of drug displacement, class, parang ganito kasi yan, ang scenario dyan. Okay? Isipin mo, class, ito yung protein. Ito yung protein. Okay? Now, halimbawa, ito yung free drug. Here's the free drug. Yung free drug na yan, may affinity towards the protein. So, bound siya dito. Nagbabind siya. Okay? Now, here comes another drug. Okay? Here's another drug, si triangle. Okay? Si triangle, mas mataas ang affinity niya kay protein. Okay? Mas mataas ang affinity niya towards kay protein. So, dahil occupied na siya, okay, kumbaga may nakabind na naggamot sa kanya, mas mataas ang affinity nito, ng triangle na to, ni drug na to. So, ano mangyayari kay, pangalanan na nga lang natin, si drug A at saka si drug B. I'm sorry. Okay? So, ulit natin yung kwento. Si drug A nagbind sa protein. Alright? Nagkataon, nag-administer ka ng isa pang gamot, si drug B. Si drug B, mas mataas ang affinity towards kay protein na to kaysa kay drug A. So, ano mangyayari? Dahil binigay mo si drug B kasabay si drug A, si drug B mataas ang affinity kay protein, ang tendency, class, si drug A madi-displace. Si drug A ngayon biglang naging free drug. Okay? Naging free drug siya ngayon. Ngayon dahil siya ay free drug, right? Pinalitan siya ni drug B. So, ang tendency, class, this drug can elicit, has increased efficacy. Ay, not necessarily increased efficacy, sinasabi natin, class, na may effect siya. Okay? Dahil free drug siya. And therefore, pwede rin siya maklear. Pero dahil, class, isipin nyo na lang, paano kung napakaraming drugs ang biglang na free? Okay? Balikan natin yung scenario kanina. Sabi natin, if a drug is highly protein bound, then increase the loading dose, right? Okay? What if that drug, binigay ko kasabay ng isa pang drug that can actually displace that drug A from its protein? So therefore, class, ang assumption ko, dapat, dahil highly protein bound siya, tasan ko ang dose. Okay? Tapos, hindi ko alam na may nagko-administer pala, may kino-administer pala akong gamot na mas mataas pa ang protein binding kaysa sa drug na una kong binigay. So, anong nangyari sa nauna kong binigay? Mataas ang loading dose. Tapos ngayon, dahil binigay ko yung si drug B, ang tendency, masyadong marami naman ang madi-displace na drug A. Okay? So, pag na-displace lahat yan, ano ang kalalabasan nito? Ina-assume ko dapat na protein bound, pero dahil nagbigay ako ng drug B, na-displace sila, so ngayon, ang dami ng free drug. So, pag masyadong marami ang free drug, okay, sabi natin, tumataas ang efficacy to the point where tumataas ang risk for toxicity. Okay? So, pwede naman maging toxic na yun sa patient ko. So, kawawa naman siya. Alright? So, yan. Okay? So, that's how competing molecules can affect protein binding. Right? So, it simply displaces. So, parang, kumbaga klase isang relasyon ang usual example ko dito would be in a relationship. Kunwari si drug A, niligawan si protein. Sabi natin si drug A ay isang mabait na tao. Siya ay mabait. Okay? So, siya naligaw, so in-entertain naman ni protein. Biglang may dumating si drug B na pogi, mayaman, matangkad. Lahat na nangahanap mo sa isang lalaki. So, obviously, kayo sasama si protein. Okay, syempre dun siya sakay, pogi na, matangkad, mayaman, sabihin natin matalino. Okay? So, nasa kanya ng lahat. Alright? So, obviously, class, in terms of affinity-wise, si protein, mas mataas ang affinity niya towards kay drug B. Okay? So, therefore, ano nangyari kay drug A na mabait lang? Na-displace. Okay? Na-ghosting na siya. Right? Kasi si protein, in-entertain na si drug B. Alright? Pero, I hope that makes sense. Alright? Okay. Okay. Right, so here are just some other diseases that could affect the total protein content of the bloodstream. So these are some of the diseases that can cause hypoalbuminemia, okay, meaning low protein. And here are some diseases that could increase protein naman. Or to be more specific, the albumin. Okay, then here are some diseases that could decrease alpha-1 acid glycoprotein, and those that can increase alpha-1 acid glycoprotein. Okay, for decrease isa lang naman, nephrotic syndrome lang naman. Okay, all right. Now, let's talk about class depot storage. So in terms of depot storage class, what we will be discussing more here would be about lipophilic drugs, depositing in adipose tissues. Okay? As you can remember, class, like dissolves like. Okay? So therefore, lipophilic drugs oftentimes have a higher affinity towards the adipose tissues upon administration. Okay. Now, class, let's discuss about volume distribution. So as I've told you a while ago, one of the key kinetic parameter class used to assess the extent of distribution is the volume distribution. Okay. Now, the volume distribution class is simply the volume of fluid required to contain the total amount of drug in the body at the same concentration as that present in the plasma. So the minimum VD oftentimes must be at least equal to the plasma volume. And the formula for VD class is equal to VD equals total amount of drug in the body, which is simply the dose over drug concentration. Okay? Now, how were we able to derive this formula? So this formula class was actually derived using the principle of one compartment model, okay, which we will be discussing in our succeeding lessons. So class, based on the one compartment model kasi, ang assumption natin here is we are looking at the body class as a glass of water lang. Okay, meaning there are no barriers. So this is one way to simplify the concept of how drugs are how we can compute for the concentration of the drug. So it's a compartment, it's a model. It's a mathematical model. So we see the body as a glass of water. So meaning class, if this is your body, okay, ibig sabihin lang doon yan, the body is simply a container, then within it class is purely water without any barriers. Now, of course, class, we all know that this is not true. Okay, ang katawan natin is full of barriers and so many semi-permeable membranes separating one tissue organ to another tissue organ or organ system, sorry. Okay, so hindi naman talaga gaya ng katawan natin. Pero, this is a mathematical model that we can use to simplify lang the computation. Okay, now normally, class, diba, a glass of water will obviously have a glass. Okay, this is the glass and will have fluids. Now, yung volume nito, class, of course, this fluid will have a volume. Okay? Now, assuming, class, this is a drug, okay, with a certain amount, so we say that's the dose, lagay mo yan sa basong tubig na ito, di ba, class, after a while, matutunaw yan, and the drug is going to spread all throughout the water. Okay? Then, this glass of water, class, will now have a specific concentration. Now, how do we compute for the concentration, class, of a glass of say for example, a glass of water or a glass of juice pala? Okay? So, paano ko makukompute yung concentration nito? Di ba, class, ang computation natin for concentration, or sorry, the formula for concentration is simply weight of solute over volume of solution. Okay, di ba ganyan lang naman yan? Now, sabi natin, class, itong glass of water na yan is equal daw to our body. Okay? So, palitan natin, class, yung mga parameters na meron tayo dito. So, instead of simply concentration, class, this will be your plasma concentration would be equal to ano yung weight ng gamot. That's the dose. Over, ang volume na yan, class, the volume na to is actually your volume of distribution. So, transpose the formula, class, you'll get the formula for VD, which is simply dose over CP. And again, class, this is simply derived from the formula of concentration. Now, if you're looking at this now, right now, class, if you're looking at this right now, okay, this formula here is actually good for an IV dose. Bakit? Sa IV. Kasi, ang assumption natin dito is, at 0 time, plasma concentration will be at its maximum. So, instantaneous yung distribution dito. Kasi di ba sabi natin, paglagay ng gamot, instant yan dapat nag-distribute. So, therefore, ano lang ba ang route of administration that would provide us instantaneous distribution? That's an IV route. If you're going to make this formula, class, extravascular, ano lang kailangan ko idagdag dito? I'll add a specific kinetic parameter here, which is F. F refers, class, to, oops, hindi na pala basa. Alright? F here refers to bioavailability. Okay, that's the bioavailability factor. Once na may F na, class, dito sa equation natin, dito sa formula natin, automatic extravascular yun. Actually, pwede rin naman sa intravascular yun eh. Kasi ang F mo for an IV would be 1. Pero ano pa ang sense ko na ilagay ko dito yung 1? Pareho lang naman yun. Okay, wala namang magiging significant effect yun sa equation ko, right? So, hindi ko na sinusulat madalas yun. Alright? Pero kung extravascular yan, di syempre 0.9, 0.8, so magkakaroon ng significant effect yun sa equation. Okay? So, yun. That's that. Now, the volume distribution, class, can be classified into two main parts. We have the central volume and then the peripheral volume. When we talk about the central volume, class, this is the volume of fluids in the central compartment, or those organs that are highly perfused. Okay, so it's a hypothetical volume into which a drug initially distributes upon administration. So this compartment can be thought of as the blood in vessels and tissues which are highly perfused by the body. So the central volume, class, may be calculated as follows. So VD equals dose divided by peak serum levels. Or yung equation na sinulat natin kanina. Simply VD equals dose over CP. Pero let's be more precise nga pala, class. Anong CP to? This is CP sub 0. Or the, sabi natin, pag CP sub 0, that's the initial plasma concentration. Or we call this the plasma concentration. Plasma drug concentration at 0 time. Okay? And oftentimes, class, if this is given intravenously, then that should be 100%. Okay? Meaning, it will be at its maximum. The plasma concentration will be at its maximum. What about the peripheral volume, class? It's the sum of all tissue spaces outside the central compartment. So all drugs initially distribute into the smaller VC before distributing into the peripheral volume. VC and VT creates the apparent volume distribution. So when we say, class, apparent volume distribution, that's already the combination of both the central volume and then the peripheral volume. Okay? Normally, class, di ba? Gawa tayo ng example dito. Kunwari ito, class, yung bloodstream. Okay? Kunwari magbibigay ako ng IV drug. Alright? Magbibigay ako ng IV drug. Ito yung syringe. Okay. Pag nagbibigay tayo, class, ng gamot, di ba, initially, lalo pag IV drug, saan siya unang pupunta? Sa central volume. Meaning sa bloodstream, andito yung gamot ko. Right? Pero, halimbawa, class, ang gamot ko to is lipophilic. Obviously, class, saan siya mas may higher affinity? Okay? Dahil siya ay lipophilic, automatic, class, pupunta rin yan sa adipose tissue. So, therefore, class, yung volume na occupy ng adipose tissues ko, or what we call the peripheral volume, class, we have to take that into consideration as well. So, class, the combination of both the central and the peripheral volume comprises the apparent volume of distribution. So, apparent VD is simply the combination of VT and VC. The central volume and then the peripheral volume. So, are we clear? Okay, so kumbaga yun yung buong volume inside the body that's being occupied by the drug. So, apparent volume distribution class is the hypothetical volume of body fluid in which the drug dissolves. Now, take note class, it's a hypothetical volume. It does not refer to a true anatomic or physical volume. Okay? It's needed class to estimate the amount of drug in the body relative to the concentration of drug in the plasma. So, most often than not class, ginagamit natin ang VD as a assumed value so that we can compute for a resulting plasma concentration or a desired dose na gusto natin makuha. Okay, so basically class, importante ang VD class when we do computations. Okay? So, the VD class is often computed as follows. So, this is the computation of VD after an IV bolus injection. So, it's simply the dose of the drug given by IV bolus divided by the extrapolated drug concentration at 0 time. Remember, class, we've mentioned before, it's impossible to get concentration at 0 time. So, more often than not, we assume the value. So, most of the time, we extrapolate it, okay, upon plotting, or we can compute for it. Pero basically, class CP0, concentration at time 0 is always an assumed value. It's always an assumed value. Okay? So, this is the equation class for an IV route. Pero pag yan extravascular, sabi ko nga, magdadagdag lang tayo ng isang parameter dyan, which is the bioavailability factor. Okay? Or the fraction of the drug absorbed. F here actually stands for fraction of drug absorbed. So, ilang percent yan? 80% ba? Is it 90%? 75% absorbed? Okay, and it will always be expressed class in decimals. Right? So, yan ay 0.8, 0.9, or 0.75. Okay? So, let's have an example here, class. A new aminoglycoside antibiotic, 5 mg per kilogram, was infused intravenously for 30 minutes to a 70 kg volunteer. Determine the VD if the plasma concentration at 0 time is 7 micrograms per ml. Right? So, ang hinahanap natin dito, class, is simply VD. Susunod po natin yung given. Ang given natin would be the dose. Ano yung dose? 5 mg per kg. Okay? Ano ang weight ng patient natin? 70 kilograms. So, therefore, class, multiply. Sige, mamaya na pala. And then, the CP0 times 0 is 7 microgram per ml. Okay? So, kuha lang tayo ng calculator. So, unang gagawin natin dyan, class, compute for the dose. So, 70 times 5. Required nga pala is VD equals unknown. So, solution, compute mo natin yung dose. Okay, 5 milligrams per kilogram times 70. Cancel. 5 times 70, we have 350 milligrams. Okay? Now, before I forget nga pala, class, VD class is only expressed using 1 unit. And what's that? It's only expressed in liters. Okay? VD is only expressed in liters. Am I clear? We don't usually express it in ml. We don't express it in any other form, in any other unit. It's only expressed as liters. Yun yung volume distribution. So anyway, 350 milligrams ang dose natin. So to compute for VD, sabi natin, kailangan ko lang naman is dose over CP sub 0. Okay? Now, looking at my plasma concentration times 0, naka-microgram per ml siya. So, anong gagawin natin? We need to convert the units. Alright? Tawag dito. Nasaan yung minute? So, 1 million. 1,000. Tama, 1 million. Pag grams. So, 1,000 milligrams lang. Sorry. So, 1,000 micrograms, is to 1 milligram. Okay, and then in terms of ml, So, sa denominator, so ang aking ml would be 1,000 ml is to 1 liter. So, anong gagawin natin dito? Cancel, cancel. Actually, as is yan. Okay? So, mangyayari class, this will be equal to 7 milligram per liter. Alright? Now, something nga pala class that oftentimes pwedeng malito ang mga students. Okay? Most often than not class, ang expression kasi ng plasma concentration will always be in micrograms per ml. Micrograms per ml. Remember class, ang madalas natin kinocompute dito is VD at saka dose. And VD and dose is often VD and dose. And most often than not class, VD is expressed in liters and dose is expressed in milligrams. Okay? So class, 1 microgram per ml, tandaan nyo to is always equal to 1 milligram per liter. Equal yan. Okay? Pinakita ko lang to para lang malaman nyo na pag kinonvert mo yan or kinonvert mo yung units, it will give you the same value. Right? So 7 microgram per ml is equal to 7 milligrams per liter. 1:1 ang ratio nila. Right? So therefore, ang dose ko dito would be 350 milligrams divided by 7 milligrams per liter. So cancel, cancel. 350 divided by 7 give you 50 liters. So therefore, class, the volume distribution here would be 50 liters. So very good. Ang dali lang, di ba? It's simple. Okay, pero class, once na we use this for other applications, for computations, it becomes a little complicated, pero tolerable pa rin. Right? So distribution volumes are important for estimating the amount of drug in the body, peak serum levels, and clearance. How? Diba sabi natin in terms of amount of drug in the body, this refers to CP. So CP0 equals dose over VD. Kaya kailangan dyan ang VD. Sorry. Ito pala yung peak serum. Ano ba yan? CP0 equals dose over VD. When we're talking about the amount of drug, okay, we're actually referring to the dose. Sorry about this. So that's dose equals CP0 times VD. Again, kailangan pa rin ang VD dyan. Or we use class the volume distribution to compute for clearance. And to compute for clearance class, CLT, CL na lang, is simply VD times K. Actually, marami pang formula for clearance that uses VD, pero ito yung pinaka-basic. So, clearance is equal to volume distribution multiplied to elimination rate constant. Okay? And if you still remember, K can be computed using your half-life, 0.693 divided by half-life. Okay? Sometimes kasi I'll be giving you case studies wherein I'll just give you the half-life. Okay, so kayo mag-compute ng K ng gamot or elimination rate constant. Okay? Okay. So, what's the effect of protein binding on VD? So, we've mentioned this a while ago. Okay, di ba? Highly bound drugs have smaller VD. Okay, explain natin kasi that if a drug is protein bound, it's bound to proteins, it stays in the bloodstream. So, therefore, sabi natin ang formula lang naman kasi ng VD equals dose over CP. So, the more a drug stays in the plasma or in the bloodstream, bumababa ang VD. Okay, in terms of proportionality, they are inversely proportional. So, drugs that are extensively bound to both tissue and plasma proteins have very large VD. Okay, this one is tissue. Nasa tissue na. Right? Kumbaga papunta sa target sites. And displacements of drug from plasma proteins will result to a transient increase in VD. So, displacement in terms of drug displacement. Okay? Why will the VD increase? Kasi mas dadami ang free drugs. Okay? Available for distribution and binding to their target sites. Extensive drug binding in cells increases the apparent volume distribution. Okay? And when no drug binding occurs in tissue and plasma, the volume distribution will not exceed the real anatomical volume because some drugs do not obey binding rules, such as in the case of isoniazid, heparin, and lithium. So these are drugs class, just so you know, heparin, lithium, and isoniazid, these are drugs that do not bind to plasma protein. So therefore, class, ang VD nila will most likely not exceed a real anatomical volume. Now, the usual kasi class volume of the body is 40 liters. This is the average. Okay? 40 liters class is the average volume of a 70 kilogram person. Okay? Yan yung total fluids from head to toe ng isang 70 kilogram person. So if you're using class drugs like isoniazid, heparin, or lithium which do not undergo protein binding, hindi pwede mag-exceed sa 40 liters yung kanilang VD. Okay? Kasi pag nag-exceed yan, saan napunta yun? Okay? So something like that. So are we clear? Okay. Now here are just some class assumptions based on the VD. Okay? We can make assumptions kasi class based on our computed VD. So if it's approximately 5 liters, we can say that the drug is solely confined in the circulatory system. Ibig sabihin, hindi siya lumalabas. Mababa lang yung VD, 5 liters lang eh. Okay? So oftentimes, class, if it's approximately 5 liters, we can assume, again, that the drug is in the circulatory system. If it's between 10 to 20, we can say that the drug is distributing itself into the extracellular fluids. If more than that, 25 to 30, approximately, nasa ICF na yun, intracellular fluids. If it's approximately 40 liters, ito sinabi ko yun ito yung average volume ng isang 70 kilogram person. We can assume that the drug is distributing from head to toe, the whole body fluids. If it's more than 40 liters class, 100 to 200, which is true, okay, you can get computations like this, or more liters, it means class that the drug is already distributing in deeper tissues. Okay? Deeper tissues or is bound to a specific biological material. Specifically, class, tissues of their target sites. Now, normally, class, a good example of this would be digoxin. Digoxin class can have a volume distribution as high as 500 liters. Okay, kasi digoxin class is highly bound to the tissues or the tissues class of the heart. So they don't stay too long in the bloodstream. They go directly to the tissues of the heart. Okay, and most often than not, class, if you're looking for concentration of digoxin in the blood, normally class ang hanap mo dyan is in nanograms. Ganun kakonti na lang ang natitira sa bloodstream. Kasi again, majority pumupunta na agad sa heart tissues. Okay? Now, class, what's the application of volume distribution? So the concept of dosage regimen. We'll have a more in-depth discussion of this in our next lessons. Okay? Pero now, class, let's give you a brief background. Okay? Regarding loading dose and maintenance dose. Why do we give loading dose, class? We give loading dose to initiate therapy. Initiate therapy or to have a quick response. Okay, para magkaroon ng mabilisang effect yung gamot ko. Kaya tayo nagbibigay ng loading dose. And most often than not, class, loading dose is twice as much as the maintenance dose. Now, why do we give maintenance dose? Obviously, class, we give maintenance dose to maintain, obviously, effects of drugs. Oops. Okay? So, we want to maintain the effects of the drugs. So, kung baka, class, if I'm giving a maintenance dose, I want my drug to stay within the therapeutic range. Okay? Because sabi natin, within the therapeutic range, we say that the drug is both safe and effective. Now, ano naman yung concept ng multiple dosing? Okay? We say, class, that we give the drug multiple times, di ba, para ma-maintain yung kanyang effects. Para ma-maintain yung effects niya. Now, normally, class, if you look at this, let's have a graph here. Okay? Di ba alam natin, class, kung ilang dose ang binigay based on the number of peaks, based on the number of Cmax that we see. So if we see something like this, gumanon agad. Okay, ano ibig sabihin nito? Ibig sabihin nito, class, binigay ang gamot once lang. Bakit? Isa lang yung peak concentration na nakita ko dito. Now, pag ganyan, class, isang beses mo lang binigay ang gamot, let's say this is the MEC. Okay? Magkakaroon ng effect ang gamot because it went above the MEC, pero mawawala din afterwards. Now, syempre, class, I want to, especially kung halimbawa maintenance drug ito, I want to keep the effect of the drug. Okay? I want to maintain its effect. So if I want to maintain it, class, dapat hindi ko hayaang bumaba sa MEC. Okay? I would not allow my drug to go below the MEC. Correct? Kasi mawawala yung effect nun. So before it goes down the MEC, I need to administer another dose. Now, normally before the MEC is reached, magbibigay na ako ng bagong dose. Now, class, if I give the same amount, okay, if I give the same amount, say for example, this 500 milligrams. If I give 500 milligrams of the same drug, same dose, yung height nito will be the same as nung height nito. Tama? Kasi same lang naman na 500 milligrams yan. Okay? Yun nga lang, class, dahil may natitira pang gamot sa loob ng katawan mo, di ba hindi pa na-eliminate lahat yan, nagbigay ako ng bagong dose. So obviously, papatungan ko yung natitirang concentration na yon. Kaya class, yung second dose ko would be obviously higher than my third dose, than my first dose. So same thing. So magbibigay ulit ako at the same same frequency, at the same dosing interval. So class, tataas ng tataas yun. Tama ba? Kasi papatong ako ng papatong sa natitirang gamot sa loob ng katawan mo. Now, ngayon, ang question is, sir, kung ganyan pa lang nangyayari, ibig ba sabihin yan, if I'm taking the maintenance dose, I'm going to reach the MTC, which is what we don't want, right? Ayaw natin ma-reach yung MTC kasi pag na-reach na yan, magkakaroon ng toxic effect yung patient. So, sir, pag patong ako ng patong, maaabot ko na yan. Okay? So, sa awa ng Diyos, class, hindi naman ganon. Kasi, ang nangyayari dito, class, you reach a point where the peak concentration, ganito na lang itsura niyan. Okay? Ano nangyari dito? The drug, okay, we say that the drug has reached what we call, class, the steady state concentration. Steady state. Okay? In steady state, class, this is the point where we say that the amount of drug being absorbed is equal to the amount of drug being excreted. Okay? Remember, class, how we reach steady state? This is based on, or the time to reach yan, ha? Steady state is equal to half-life multiplied to 4 to 5. Okay, remember this? Nung nag-discuss tayo about half-life, we say, class, diba, it takes about 4 to 5 half-lives to reach steady state. Okay, so whatever the drug's half-life is, simply multiply it 4 to 5. So kung ang half-life ng gamot mo is 4, tapos multiply mo yung 4 to 5, ang lalabas dyan would be 16 to 20 hours. So, ibig sabihin, after 16 to 20 hours of continuously giving the drug, it's going to reach steady state. So, this is, kung ito yung gamot na yon, nag-start yan after the 20th hour na. Assuming na lang, i-maximum na natin. Okay? But actually, it's between 16 to 20 hours. Pero, just to be on the safe side, sabihin na lang natin, after 20 hours, the drug reaches steady state. So, sabi natin, class, dito, the amount of drug absorbed is equal to the amount of drug eliminated. Okay? We had a similar concept like this, right? The Cmax. Okay? Kung ito yung graph, Cmax wherein Ka equals Ke. The amount of drug absorbed is equal to the amount of drug eliminated. Same thing happens, class, when you start reaching the steady state concentration. Okay? The CSS. We call this the CSS. Alright? The CSS. Now, class, kung CSS na yung ating term dito, okay, it's actually almost similar, class, to your CP0. Okay, wherein, pag the formula natin, class, is multiple dosing. Okay, basta pag multiple dosing, class, ang hinahat na dyan is CPSS. Pero pag single dose, that's CP sub 0. Are we clear? Yun yung Cmax dito. Pag multiple dosing, ang Cmax dyan would be CPSS. Both of which are referring to Cmax. Okay? Both of these are referring to your Cmax. Yun nga lang, pag CPSS ang terms na ginagamit natin, it means I'm giving the drug multiple times. Okay? Pero pag CP sub 0, it only means I'm giving the drug once. Okay? So are we good with this? Alright. Ayan. So, kung magko-compute ako ng VD, pwede ang formula ko class would simply be dose over CPSS na lang. Ibig sabihin, I'm giving this drug multiple times. I'm going to give this drug multiple times. Alright? Sa CPSS ang ginamit kong term. Okay. Oops. Oops. Tayo. Ayun. Okay. So, loading dose class. Why do we give loading dose? Sabi natin, it's the amount of drug that, when dissolved in the apparent volume distribution, produces the desired steady-state concentrations or the desired plasma concentration. And again, class, that CSS should be within the therapeutic range. Okay? So, kung ito yung ating graph ulit, MEC, MTC, yung CSS na yan, dapat within the therapeutic range. Yung desired CSS na yun. Yung steady state plasma concentration. The steady state, the peak plasma concentration. It is given as initial IV bolus to produce CSS as rapidly as possible. Kaya oftentimes, kasi pag nagbigay ka ng loading dose, at 0 time, andito agad yan. Hanggang sa baba yan. Alright? Kasi gusto mong ma-produce agad yung effects. So, it is sometimes used at the onset of therapy when therapeutic concentration must be achieved rapidly and the volume distribution is high. It is unchanged in patients who have impaired renal or hepatic function. Now, please take note, class, not all drugs are given loading doses. Ano exception to the rule? We don't give loading dose, class, if we know that the drug's toxic side effects occur at high doses. Example of which, class, are antipsychotic drugs. If you give a drug class, if you give antipsychotics with loading dose, ang tendency is lumalabas agad yung side effects ito, okay, such as extrapyramidal effects, which we do not want. Okay? So those are exceptions to the rule. Not all drugs require the use of a loading dose. So again, class, the formula is simply for IV drugs. It will just simply be desired plasma concentration, desired steady state concentration, multiplied to your VD. This is IV push. Okay, this one naman, class, on the other hand, this is a computation for an IV infusion. Okay, ano naman yung RO na yan? That's the rate of infusion. So, loading dose simply equal to rate of infusion. Okay, ano yung infusion rate mo? Is it, it's usually expressed in ml per minute. Alright, how many ml of drug is being administered per minute? Usually ml per minute, divided by K, or simply your rate of elimination. Okay? So, yan yung formula natin, class, for an IV infusion. Again, mas madali, class, ang IV push. Saan to nanggaling? Yung CP0 equals dose over VD. Transpose ko kasi to. Dose equals CP times VD. Nagkataon nga lang ngayon, ang CP ko will be a desired steady state plasma concentration. Kasi sabi natin yung CPSS na yan nasa therapeutic window. Okay, at yan yung concentration that will give the desired pharmacologic effect. Okay? Are we clear? So ito, CPSS, usually is the desired drug concentration. Okay, concentration that will give effects. That is safe. Okay, that is safe. Now, what about maintenance dose, class? So maintenance dose is used to maintain the plasma concentration of a drug within a specific range over extended periods of time. So it's given at a dosage interval equal to the elimination half-life, oftentimes, of the drug. Then loading dose equals twice the maintenance dose. So it's decreased in patients who have impaired renal or hepatic function. So kailangan babaan yung loading dose pag ganon. And it takes about 4.32 to 6.65 half-lives respectively to reach 95 or 99% of the CSS without a loading dose. Now, the formula for this class is simply clearance multiplied to the desired plasma concentration, okay, multiplied to your dosing interval. Tau here, class, refers to dosing interval. Ito yung every 8 hours, every 12 hours, every 4 hours, mga ganon. Yun yung dosing interval dito, class. Okay? Now, please take note. I don't know if you've noticed this class, wala tayong dosing interval na number that cannot divide 24. Why? Because our dosing interval class should be a number that can divide 24 so that we can give the drug at the same time every day. Okay? Wala kang makikitang dosing interval na every 11 hours or every 9 hours. It's always every 8 hours or every 12 hours. These numbers can divide 24 hours. Alright? Okay. Then divided by the bioavailability. So kung yan ay IV, automatic 1 na yon. Okay? Pero kung yan ay oral or extravascular route, so medyo magkakatalo yon. Okay? Now the formula below class is simply an expanded formula of the formula here, the first formula. So here's the first formula, here's the second formula. Ang second formula class is just an expanded formula of the first one. Kasi clearance, di ba sabi natin kanina, it's VD times K. So, in-expand niya lang. So, yan ang formula ngayon. So, are we good? Okay. So, let's have here, class, a sample problem. Mr. Jones is admitted to the hospital with pneumonia due to gram-negative bacteria. The antibiotic tobramycin is ordered. The clearance and VD of tobramycin in Mr. Jones is 80 ml per liter and 40 liters respectively. What maintenance dose should be administered IV every 6 hours to eventually obtain average steady-state plasma concentrations of 4 milligrams per liter? And then, ito na yung answer. And then for number 2, if you wish to give Mr. Jones an IV loading dose to achieve the therapeutic plasma concentrations of 4 milligrams per liter rapidly, how much should be given? So let's write here, ano bang given muna natin? So we have the clearance, which is equal to 80 ml per minute. We have a VD, which is 40 liters. And then the desired CPSS, ang sabi niya, ang gusto natin is 4 milligrams per liter. Tapos ang ating dosing interval is every 6 hours. So ang required sa atin is maintenance dose at saka loading dose, both of which are unknown. Solution, madali to kasi IV. Okay? So bibigyan natin ng gamot IV eh. So the maintenance dose, IV daw, anong dose ang ibibigay ko pala? Okay, so it's given to be, tama ko? Alright, so IV push to most likely, hindi mo sinabing IV infusion eh. So therefore, ang loading dose is simply CPSS times VD. So unahin natin yung number 2. So desired CPSS is 4 milligrams per liter times ang VD, which is 40 liters. Cancel. And that will give you 160 milligrams. So good tayo dyan. Got that one. What about the maintenance dose? Maintenance dose, ang sabi natin, that's clearance times CPSS times tau over bioavailability. Now, since ang gamot natin is IV, obviously, ang bioavailability ko will be equal to 1. So, kahit hindi ko na isulat. Okay? So, anyway, ang clearance natin would be 80 ml per minute times 4 milligrams. Oh, dito tayo magkakaproblema ngayon. Okay? Kasi ang ating clearance is in ml per minute, ang ating tawag dito. Ang ating CPSS is in milligrams per liter. So, pili ka, ano yung convert mo? Okay, in my case, class, I prefer to convert my 80 ml per minute to 80 liters per minute into liters per minute. Okay, so dito natin ilagay sa isang side. So, 80 ml per minute. So, that's equivalent to 1,000 ml is to 1 liter. So that's 80 divided by 1,000. You get 0.08 liters per minute. Okay, so 0.008. This is liters per minute times 4 milligrams per liter times 6. Okay? 6. So cancel. Oh, ito pa pala. Ang hours ko, I need to convert this into minutes. Alright? So, madali lang naman to. 1 hour equals 60 minutes. Cancel. 6 times 60. That's 360. So times 360 minutes equals 360 times 4 times 0.08. We get 115.2 milligrams. So we got it here. Now you might be wondering, class, why did I write here 120 milligrams or 120 milligrams? Okay, the reason for that, class, is, okay, mahirap sa part ng nurse mag-withdraw ng dose equivalent to 115.2 milligrams. Ganun ka-precise. Mahirap kunin yun. So oftentimes, class, what we do in practice, in clinical practice, is we round it off. Okay? Ni-round off natin yung dose natin to the point, class, wherein madali siyang i-withdraw sa vial. Okay? So tulungan din naman natin yung nurse natin. Okay, mag-alala, sa therapeutic window naman yan, bandang kalagitnaan. So konting taas sa dose, class, most likely hindi mo naman ma-reach ang MTC nun. Okay, so okay pa naman yan siguro, most likely. Pero, class, in clinical kinetics, what we do is, pag nag-a-adjust tayo ng dose, either you increase or decrease, we still check via computation kung maabot ba ang toxic concentration o hindi. Alright? Pero in our case, class, in our subject, so basic biopharmaceutics and pharmacokinetics, let's stick muna to the actual numbers that you compute. Saka natin pag-isipan yung mga pag-round off na yan. Okay? Pag nasa clinical pharmacokinetics tayo. Right? Okay, so with that, class, that's the last slide that we have. Okay, so I hope you learned something, and let's proceed to our next lesson.